Hello, everyone. Good morning. It's my pleasure to welcome Dr. Bagrodia here to our grand rounds over at UCSF. He's an associate professor at UC San Diego. He did his training at UT Southwestern and fellowship at Memorial Sloan Kettering. He is a thought leader in many domains in urologic oncology, but particularly in germ cell tumor. And I'm super excited for his lecture. I could go on, but I'm going to share a few fun facts as well, because I like to do that when I introduce folks. If you guys haven't gotten a chance to listen to his podcast, Backtable Urology, I'm going to put a plug in for that. It's really amazing and very relevant to all urologists across all aspects of training into being an attending and a practicing urologist. There's a lot of really interesting topics, so you should definitely take a look. And then another fun fact is he is an amazing cook, in particularly Indian food. So if you're ever in San Diego and you can score an invite to his house, you will then understand why I love him so much. Because aside from all these accolades and a million publications and funding, he is a pretty amazing human being. So I'm very excited for his talk today.
Thank you, Seema, for the invitation. This is really an honor to be here, particularly since getting out on the Western section, I've gotten to know a lot of the residents, fellows, attendings, and alumni from UCSF. And it's really a pleasure to feel so welcome into the Western section. And it's an amazing program, absolutely incredible. So this is truly, truly an honor to be here today. Looking forward to talking about germ cell tumors, testicular cancer, some of the updates, kind of where we are and where things are going. Feel free to ask questions over the course of the lecture. That's perfectly acceptable and invited. And I hope when it's all said and done, many times I think people, when they consider germ cell tumors, they feel like this is a pretty easy disease. We can, maybe just get by with our typical stuff and patients will be okay. But I think there's opportunities for improvement. And, I believe that perfect or good is the enemy of perfect. So hopefully that'll come across a little bit over the course of the talk. Thank you again for the invitation. So here's some disclosures. None of them are relevant, and I apologize in advance. I have a fairly annoying post-URI cough. So just some basic demographics about testicular cancer. Important to recognize it's still responsible for the most life years lost for non-pediatric cancers. It's the most common cancer in men between the ages of 18 and 45, with about 10,000 new cases per year. The demographics of testicular cancer, particularly in the United States, are changing. The highest rise in incidence is among Hispanic men. The underpinnings for that are largely unknown. And while we generally can do an excellent job curing these young patients with germ cell tumors, there's still about 500 deaths per year. So absolutely an opportunity for improvement. And when I think about testis cancer, kind of broad strokes across the disease spectrum, the diagnosis between a physical exam, a history, tumor markers, and ultrasound, that's usually pretty straightforward. But after that, there's plenty of uncertainty that surrounds testicular cancer diagnosis and management. For patients with stage 1 disease, this is the most common clinical setting. For the trainees who have their in-service right on the corner, stage 1, it's easy enough to remember. These are tumors that are confined to the testicle. We're trying to provide a patient with some degree of counseling on who will relapse. Stage 2 disease, this is going to be retroperitoneal disease. Of course, testicular cancer follows a very predictable pattern of metastases. The testicles begin around the level of the renal hyla. They descend into the scrotum shortly before we're born. And that path of descent is where testis cancer tends to metastasize in about 90% of cases. And that's also why we can take advantage of local regional treatment options like retroperitoneal lymph node dissection and radiation therapy. We know from large surgical series for patients that have small nodes less than 2 centimeters in the retroperitoneum, if we went in and removed all of those surgically, we would overtreat almost 20 to 30% of patients who would have pathological and zero disease. We also want to select out the group of patients that likely wouldn't be benefited from local regional therapy because they're destined to develop metastases and most commonly in the lung. And then in the post-chemo setting, whether it's non-seminoma germ cell tumors or seminomas, our ability to predict who would benefit from further treatment, whether that's post-chemo RPLND, salvage chemotherapy, or the relatively rare case of RPLND in the context of metastatic seminoma, is very, very limited at best. So a lot of questions as it stands in testicular cancer management. And when thinking about these young cancer survivors who have 50, 60, 70 years of life ahead of you, I think it's always critical to think, in addition to maintaining these excellent cancer outcomes, it's paramount to minimize the toxicity and the side effects, adverse effects that patients may have to contend with for the remainder of their lives. So with that introduction, we'll run through some clinical scenarios in stage 1 and stage 2 disease. I'll talk a little bit about microRNAs for germ cell tumor diagnostics and what the data shows regarding microRNAs and clinical application across the germ cell tumor spectrum. So, in my opinion, testicular cancer is squarely a disease that falls within our wheelhouse at urologists. From the first time we see a patient and we're counseling them, it's our job to make sure that the care is absolutely perfect, and whether that's talking about sperm banking, prosthetic placements, all of this is critical. And when we do the orchiectomy, we obtain our staging, imaging, CT scans of the abdomen and pelvis, either chest x-rays or CT scans of the chest, depending on the extent of disease and tumor markers. The vast bulk of these patients are going to have stage 1 disease. 99% of seminomas are going to be in the proportion of cases that are stage 1 and seminoma is about 85%, and non-seminoma is 70%. So those are squarely in our wheelhouse. Stage 2 disease, relatively less common, 7% of seminomas, 20% of non-seminomas. And then stage 3 disease makes up about 5 to 10% of patients. And critical to remember that in the early stage disease, stage 1, stage 2, that the survival is tremendous, upwards of 90%. And even in the stage 3 population, we can do a really, really good job. And that's when the perfect care becomes absolutely mandatory. Also, really important to remember that these statistics hold when guideline directed care is administered. So it's our job to make sure it's done really well, and also to emphasize to the patients that compliance with the treatment plan, surveillance plan, recommendations in general is critical. So for these stage 1 and stage 2 patients, that is a disease state where the urologist needs to be intimately involved. And these patients, again, have excellent, excellent survival in the early phases. So let's just kind of walk through it. We start with the stage 1 seminoma. This is an actual patient of mine, 23 years old, presenting with a painless enlarging left testis mass, no pertinent history of trauma, infection, no history of an undescended testicle. And on exam, he's got a large palpable mass involving the left testicle. On ultrasound, it's about 6.5 centimeters with hypoechoic lesion, increased flow, fairly consistent with the germ cell tumor. Markers are notable for an HCG of 129. And on orchiectomy, he has a 4.5 centimeter seminoma with some reedy testes invasion. His markers normalize, his imaging is negative. So when we think about stage 1 seminoma treatment principle, the survival approach is 100% independent of the timing type of treatment. When I see these patients around the time of orchiectomy, essentially the bulk of my counseling is that you're going to be okay, because these young men often have significant anxiety, depression, adjustment when it comes to a new cancer diagnosis. And we run through the options: surveillance, which we'll talk about being, the massively preferred option, and then single cycle carboplatin, and then adjuvant radiotherapy, which is largely falling out of favor for a variety of reasons, which I'll share with you in just a moment. So why adjuvant therapy for all overtreats the vast majority of patients, and it is associated with acute and chronic toxicities. So what about trying to risk stratify? Are there features that we can glean from the orchiectomy or otherwise that could be helpful in further refining risk? So there's been some efforts to do this. Historically, size greater than 4 centimeters and reedy testes invasion were considered high risk. Size has been validated. Reedy testes invasion has been mostly validated, and more recently, lymphovascular invasion has been suggested as as a risk factor among seminoma patients. It's a well-established risk factor for patients with non-seminoma. And if you look here, if you're very low risk with none of these risk factors, the relapse out 5-10 years is extremely low in the 6 to 8% range. If you have a single risk factor, the relapse still remains very low, less than 20%. And if you're high risk, granted, the relapse approaches almost 50%, but that's going to be a extreme minority of the patients, 4 to 5% of the patients. So even in the relatively higher risk patients, which is super uncommon, surveillance is generally going to be the recommended option for them. And the overall relapse rate is uncommon, about 50% of all patients. We see excellent outcomes with surveillance and then treatment at relapse. We'll talk about some of the ways of treating those relapse. And then in general, surveillance is going to be recommended as a preferred option, and that stands from the AUA, the NCCN, and the AUA guidelines. Now, there has been another emerging concept, moving on to clinical stage 2 seminomas. And generally speaking, these are going to be patients that present with stage 2 disease, small volume retroperitoneal metastases, as well as those patients that have stage 1 disease and then on surveillance go on to develop a recurrence in the retroperitoneum. Historically, we have highly effective treatment options, radiation therapy, depending on the bulkiness of the disease. They can receive either 30 or 36 gray. Chemotherapy, highly effective, good risk-directed chemotherapy, typically with BEP times 3 or EP times 4. Another emerging concept is going to be RPLND, retroperitoneal lymph node dissection for isolated less than 3 centimeter disease, and there's been several trials. So why this kind of renewed interest in non-chemotherapy, non-radiotherapy based regimens? So we have both survival and survivorship. And the chemotherapy, while highly effective, does have a whole host of side effects, including cardiac disease, secondary malignancies. Those are kind of the big ones that can lead to untimely death, hypertension, diabetes, metabolic syndrome, cognitive impairment. We recently hosted the Testis Cancer Awareness Foundation Summit here, patient provider facing, and the proportion of patients that talk about chemo brain or a general dulling of their senses, particularly during chemotherapy, it's profound. Ototoxicity, neurotoxicity, and then the added impact of chemotherapy on gonadal function. So there's plenty that maybe we can improve upon by avoiding chemotherapy, avoiding radiation. And these adverse effects are common. When you look at large series, multi-institutional series of patients that have been treated with systemic chemotherapy, almost 80% report an adverse health outcome, and it gets progressively worse with the amount of chemotherapy that is stratified. Why is radiation falling out of favor? If you were to receive radiation to the retroperitoneum, subsequently have a relapse requiring chemotherapy, the risk of long-term toxicities, cardiotoxicity particularly, exponentially increases. So when we're looking at the data for surgery for early stage metastatic seminoma, a relatively large phase 2 study based out of the USA. This was a conception of Sia Danishband at USC. And essentially, it was a phase 2 trial of retroperitoneal lymph node dissection as a first-line treatment for patients with isolated retroperitoneal disease. Again, both stage 2 at presentation, and then patients that were stage 1 and subsequently had a relapse. They had to have pure seminoma, relatively small volume disease, less than 3 centimeter, no more than 2 lymph nodes. The nodes had to be in the RPLND template. Again, that's the renal hyla, superiorly, the ureters laterally, and then the crossing of the iliac vessels inferiorly. Contemporary imaging, contemporary and normal tumor markers. And essentially in this study, it was identified after about almost 3 years that the recurrence rates were approximately 22%. All of those patients were safely salvaged. And this is going to be maybe a little bit higher, but consistent with the radiation literature. Time to recurrence was generally early, and all patients were alive at the end of the study. There's been 3 other clinical trials, 2 based out of the out of Europe. That's the PRIME test and co-trims studies. And when you look at the all-comer relapse rate with a relatively reasonable 2-year follow-up, which is when the bulk of these recurrences take place, it's about 15%, and all patients survive. The operations are well tolerated. All of these were done open, and the proportion of patients with grade 3 complications or worse was low, and the ability to preserve ejaculatory function, which is, of course, a risk factor for RPLND, was also relatively low. Importantly, many patients, when they look up RPLND, they find these fairly horrific images and experiences over the internet. And it used to be, a week in the hospital, long surgical times, excessive perioperative morbidity, NG tubes, difficult to control pain. But with contemporary RPLND, when done open, generally in the primary setting, this is typically a 1 to 2 day admission. The surgery is a couple of hours. The complication rates should be very low at high volume centers, and ejaculatory function should be able to be preserved, both with nerve sparing and potentially when templates when that's appropriate. There's an emerging interest in robotic RPLND. The short-term oncologic outcomes look reasonably well. And as that data matures, perhaps the convalescence profile could also continue to improve. So moving on to stage 1 non-seminoma germ cell tumors. So when a patient comes in, all comers, there's about a 30% risk of relapse. We're sitting down, we're looking at the orchiectomy, and our risk factors that we use for prediction are really quite rudimentary at best. We're looking at lymphovascular invasion, embryonic carcinoma percentage, and if you have both of these, there's about a 50% chance of having occult metastases. And tumor markers, when positive, they of course can be informative and helpful, but about 60% of them express tumor markers, the other 40% or so don't. So per guidelines, we've got some options. If you're stage 1 without risk factors, surveillance is generally going to be the preferred option. If you have risk factors, adjuvant therapy with either RPLND or a single cycle of chemo could be discussed. If you have risk factors, LVI, particularly adjuvant chemotherapy or nerve-sparing RPLND, are also a part of the armamentarium. So when sitting down with a patient, I always find this to be a bit of a challenging conversation. If we start out with surveillance, if you're in that proportion of patients who are destined to be cured with orchiectomy alone, you're good to go. However, if you relapse, historically, most of those patients were treated with chemotherapy and all of the attendant side effects, despite the fact that it's highly effective. If you give a single cycle of chemotherapy, you can drop the relapse rates quite substantially down to less than 5%. However, we do see a substantial amount of overtreatment. The long-term side effects of a single cycle chemotherapy, which is a relatively newer regimen, are somewhat unknown. And then, of course, there's surgery. The pros are it's diagnostic, and over 90% of cases with stage 1 disease, it should be therapeutic. However, it is an invasive surgery with all of the attendant side effects. Now, broadly speaking, I think if it's a stage 1A, no risk factors, the standard is going to be observation. Sometimes there can be extenuating social circumstances and so forth that may modify that approach. One caveat based on expert opinion and in the AUA guidelines, if the patient were to have secondary somatic malignancy, otherwise known as teratoma with malignant transformation in the orchiectomy, then a RPLND should be considered, as there are no salvage chemotherapy options that are effective for patients with secondary somatic malignancy. Stage 1 disease, I think it is important that all options are discussed and available to the patient. However, surveillance is generally going to be preferred. Again, the patients do quite well. We can avoid treatment, over-treatment, and subsequent harms. And there's actually emerging data, particularly with a single cycle of BEP, that if you're stage 1, you receive BEP, and then subsequently relapse, that the tumor biology may be a little bit different, and the outcomes could be poorer. Then in the stage 2 non-seminoma setting, and it's actually extending to seminoma as well, the options are generally going to be nerve-sparing RPLND or primary chemotherapy. I think the general trend is shifting towards favoring RPLND for marker negative 2A disease. It's important to look at all the features. How does the mass look? Of course, the markers should be negative, proximity to vessels, multiple nodes. And then for selected marker negative 2B disease, these might be patients that had substantial amounts of teratoma in the primary orchiectomy specimen, cystic masses, or other risk factors for a poor tolerance of chemotherapy, or for a high likelihood of having teratoma present. And the guidelines support this. RPLND or chemotherapy should be offered for stage 2A non-seminoma with normal tumor markers, and then in appropriately selected 2B patients, RPLND could be offered. I think it's critical that these patients meet with all the relevant parties, a medical oncologist, a urologist, and discuss their options. We're very fortunate to have a germ cell tumor-directed tumor board here where they meet with the medical oncologists and myself the same day to run through their options. Now, if you go and perform an RPLND, historically, and you find viable germ cell tumor on final histopath, historically, the recurrence rates for pathological N1 disease were fairly low, 10-15%, and observation was generally advised. For pathological N2 disease, the recurrence rates were thought to approach about 50%, and adjuvant chemotherapy with either EP times 2 or sometimes BEP times 3 was advised. And then for pathological N3 disease, essentially those patients were thought to have a 95% of recurring, and good risk-directed chemotherapy was generally administered. Emerging data, this is a large surgical series from Indiana, suggests that actually, regardless of the pathological end stage, in appropriately selected patients, the recurrence-free survival without adjuvant chemotherapy is actually quite good, in the 80% plus range. And the guidelines are going to be amended to essentially de-escalate the recommendation for adjuvant chemotherapy for patients that are found to have disease on histopath. And some of the things that I think we can do to optimize outcomes of primary RPLND in stage 1 disease, really close evaluation of the primary landing zone. If you're considering a primary RPLND, which I do believe are happening less and less common, you want to make sure that the markers and the imaging are contemporary, up to date. You don't want to go in there and somebody who had a CT scan 3 months ago and they have multiple enlarged lymph nodes throughout the retroperitoneum, a patient that's likely not going to be well selected to be cured by surgery alone. In the stage 2 disease, de novo stage 2 versus the development of low volume metastases on surveillance, the data is not quite robust enough to suggest that only the patients that recurred on surveillance where we have some natural history are the ones that are best candidates for RPLND. Many times in patients that present with stage 2 disease, what I'll do is actually schedule their RPLND out 6 or 8 weeks, complete imaging, CT scan, chest, abdomen, pelvis, and tumor markers a week prior. And if their nodes involute, we cancel the operation. If they develop metastases, we cancel the operation. If they have persistent disease in the landing zone that's maybe a little bit higher, we're starting to get some sense of this is a patient that we could likely help with surgery, and then proceed. And our data suggests that our N0 rates are actually pretty small, at about 5%, and that's lower than what's been reported in the literature. And then a kind of rule of 3 that we kind of use clinically is if they have more than 3 nodes, pretty reluctant about going in there for surgery. And if it's greater than 3 centimeters, also a little bit suspicious about going in there for surgery. Again, you got to look at the orchiectomy, the imaging, the timing of the development when making these decisions. A couple of other things, and some of these are tips and tricks that I've picked up talking to people that spend some time thinking about germ cell tumors, preoperative high-fat diets, so you can really see the lymphatic system and ligate any lymphatics that could lead to cholelocystis. Really took a look at the anatomy, the relational and anatomy of the arteries and veins. So when you go in there, you can move efficiently and safely, knowing when to be careful. and really define the operation and do that, whether the approach is open or robotic. You want to be familiar with the templates. If appropriate, that shouldn't be dictated by the approach. Nerve sparing and templates, those are separate ways to maximize ejaculatory function. And if doing these operations, ideally you should be familiar with that anatomy, delicate tissue handling, and to really try to control the lumbar arteries and veins and then lymphostasis. So those are some thoughts on management of stage 1 and stage 2 disease, which again I feel is squarely in our wheelhouse. And let me pause there for a second. I see a hand raised by Seema.
I'm going to ask a question that came in through the chat from Max. And I think this was a little bit ago, and it was that he said he knows the some PET data, but what has been your experience with PET pre-chemo or treatment for primary RPLND treatment for seminoma specifically?
Yeah, it's a great question. And so as a part of, excuse me, as part of this SEMS trial, it was optional to get PET scans prior to RPLND. And of the 55 patients that were accrued in the trial, about 30% of patients had a preoperative PET scan. And so it's a relatively small cohort. The positive predictive value, so if the PET was positive, was quite good. The negative predictive value was okay. It wasn't perfect. And, at the end of the day, it is a imaging-based test. So the positive predictive value, Max, was, I believe, around 90%. The negative predictive value was more in the 60 to 70% range. So I don't think it's necessarily going to be prime time standard, but there's equivocal cases where you're following the patient, maybe with short interval imaging. It could be an adjunct. And then for the sake of completeness, in the post chemo setting, generally I think PET is being phased out. The false positive rate is really, really substantially too high. One, two, the likelihood of cure with surgery, even in what appear to be well-selected patients, is lower than we thought. And then thirdly, salvage chemotherapy is highly affected, and the likelihood of requiring a post-chemo RPLND in seminoma patients after salvage chemo is very, very low. So again, just in the primary RPLND phase, it may be an adjunct in equivocal cases. You may be better suited by just repeating imaging in 6 to 8 weeks, which is of course supported within the guidelines. And in the post-chemo setting, more likely that just standard imaging demonstrating growth of a mass is more useful than a PET scan, which can cause significant confusion. Thanks for the question. And thanks for bringing that up, Seema. I don't have the chat pulled up right now. So, as I kicked off this talk, I mentioned that, there's a lot of uncertainty when it comes to testis cancer. And we do have tumor markers, which are helpful, but somewhat underwhelming. And one of the main issues is they lack both sensitivity and specificity. AFP can be elevated in a host of clinical situations, including liver disease, hepatocellular carcinoma. There can be familial elevations of AFP. HCG can be elevated in a variety of cancers: bladder, renal, gastric, marijuana use, hypogonadism, where there's cross-reactivity with LH. And then LDH is a very non-specific marker of cell turnover. And here's some of the relationship between the histology and markers. Yolk sac tumors are highly expressive of AFP. Seminomas basically don't express AFP. Choreos, super high HCG levels are part and part of choriocarcinoma syndromes. And then teratomas are variable. If we had sensitive and specific biomarkers, this could potentially allow for more precise, individualized treatment recommendations. And over the course of the next few slides, I hope to demonstrate some of the promise of microRNA 371A3P to be such a biomarker. So, brief introduction to microRNAs. These are small non-coding RNAs that are involved in epigenetic gene regulation. They're released from the nucleus. They impact the messenger RNA in a variety of different mechanisms. they impact cellular communication, and importantly, once they go through their various stages of processing, they can actually leave the cell. Now, the first kind of study looking at germ cell tumor specific microRNA came out about 14 years ago from the UK, Palmer and colleagues. And using RNA expression data, they identified a family of 8 microRNAs that were overexpressed in both adult and pediatric germ cell tumors compared to normal germ cell tumors, and notably to teratomas as well. 2 years later, Matt Murray and colleagues reported the case of a 4-year-old boy with a sacrococcygeal yolk sac tumor. AFP was about 82,000. And they obtained serum from this young patient, and using a combination of pre-amplification steps and PCR, were actually able to detect these 8 microRNAs and track them along the course of the patient's treatment and quantify them, and found that they really correlated quite well in this case report with the patient's clinical state. And this led to really an explosion of international interest and excitement about these microRNAs. One of the relatively earlier studies from the Netherlands identified 161 patients, fairly well balanced between germ cell tumor patients and controls. And what they found were microRNAs, specifically 371, 72, 73, and 67, were elevated with really unseen sensitivities and specificities in the 90% range. And importantly, in seminomas, where HCGs only elevate about 10 to 15% of patients due to the presence of syncytial trophoblasts, we were seeing microRNAs that were predictive of having a viable germ cell tumor. We did some work in the pre-orchiectomy real-world setting, patients that were coming in receiving orchiectomy for a variety of reasons, including post-chemo orchiectomy in men with advanced stage disease. And in our hands, we found that the accuracy of microRNA 371 was excellent at 94%, well outperforming conventional tumor markers who were more in the 60% range, and consistent with the literature. The largest series to date, published by Klaus-Peter Diekmann and colleagues, large series, 874 patients, 616 with malignant germ cell tumor, 250 controls. And they saw that across the spectrum, the area under the curve for microRNAs as a diagnostic test for germ cell tumors was tremendous at 97%. And even in the relatively lower volume clinical stage 1 setting, it was very, very good at 95%. So these studies in the pre-orchiectomy setting really suggest that microRNA has excellent diagnostic accuracy, and it outperforms conventional tumor markers. Now, I think as we're all fairly familiar with and aware, it's not really the pre-orchiectomy setting where there's substantial doubt when it comes to next steps. So stage 1 non-seminomas, these are cases that we see frequently. It's one of the more common disease states. We talked a little bit how our ability to predict whether that's LVI and embryonal carcinoma for non-seminomas or reedy testes invasion size for seminoma is limited at best. And I'll share a quick case. This is a patient of mine, 24 years old, T2N0M0, stage 1B non-seminoma with a fairly substantial embryonal carcinoma percentage. And I actually counseled him towards observation, as I typically do, for a variety of reasons. He wanted to be proactive and elected for an RPLND. And at surgery, he had 1 out of 33 nodes positive with a ½ centimeter focus of embryonal carcinoma. We had obtained a microRNA prior to his operation, and it was indeed positive. So when we look at some of these large studies for patients focusing on stage 1 disease, those that have an elevated microRNA after orchiectomy, their risk of relapse is very, very high in the upper 90%. We performed a study collecting serum immediately prior to primary RPLND in a cohort of patients with stage 1 and stage 2 disease. The age was about what you'd expect, 27 years old. We had a combination of histologies at orchiectomy, and the ultimate composite clinical stage was stage 1 and stage 2 in half of the patients respectively. At final histopath, about 70% of the patients did have either viable germ cell tumor or teratoma. So So I think we were selecting these patients reasonably well. And since this initial study, we've actually moved a bit away from primary RPLND in the true stage 1 setting. And we did ultimately see that the sensitivity and specificity of microRNA focusing on 371 was quite good for the detection of patients who were going to have viable germ cell tumor and those patients who could potentially safely have avoided RPLND. Others have looked at this as well. Again, the presence of a positive 371A3P test after orchiectomy is associated with about an 83% sensitivity, 96% specificity of identifying a relapse. And in a separate study out of USC with Sia Danishmend and Lucia Nappi, they focused on a group of patients with stage 1 disease, and MicroRNA 371 correctly identified all patients that ultimately occurred and those that did not. Now, while this is super exciting, there's still some ongoing opportunities for improvement. This is work from Rob Hamilton's group using their Princess Margaret experience, 151 stage 1 patients. The relapse rate is consistent, 23% with what we'd expect. There was no association with an early post-orchiectomy microRNA and relapse. However, at the time of relapse, the microRNA test was elevated in almost 95% of cases. And this is the first study that I would say tempered some of the enthusiasm of an early microRNA test to identify patients with disease. It was corroborated in a prospective study, 33 patients, done by Christian Fankhauser's group. The relapse rate was 30%, and they serially collected microRNAs over the course of surveillance and also identified that an early post-orchiectomy microRNA was not indicative of relapse. However, the levels were elevated about 2 months before clinical detection, and whether that's going to impact clinical decision making is going to be borne out in some of the large-scale clinical trials that are ongoing. We have a clinical trial going through the ECOG ACRIN mechanism, where quite simply patients who are stage 1 disease will get a microRNA test. If they're negative, they'll go on to observation with real-time assays of their microRNAs over standard surveillance periods. If they seroconvert without METs, they could go on to receive RPLND, and if they're positive, they'll go on to receive RPLND, and the primary outcome is correlating histopath. So for stage 1 disease, I think it's promising in the post-orchiectomy setting. However, early post-orchiectomy microRNA does not predict clinical relapse, and this is likely a sensitivity issue, and I have no doubt that our germ cell tumor community will be able to figure out this technical barrier. So stage 2 disease, again, this is a patient of mine, 44 years old. He had a right-sided testicular mass that was a mixed germ cell tumor. And as you can see here, there was some periaortic lymphadenopathy. It's a bit unusual to see isolated contralateral metastases. We started out, sorry about that, monitoring him and repeated imaging in about 8 weeks. He had no change. And ultimately, he went on to receive RPLND, bilateral full template. 2 out of 32 nodes were positive. And in him as well, a pre-RPLND microRNA test was positive. Recently reported our experience with refining the test and specifically looking at patients with stage 2 disease, generally a similar methodology, larger cohort. Again, clinical stage 2 disease was a substantially larger percentage of the population. And we found that the performance remains quite good with areas under the curve of 93 and positive predictive values, negative predictive values, both at 92% respectively. I think this is a sweet spot for microRNA testing, really identifying those patients who may be pathological N0 and could safely avoid surgery. And then, of course, it's intriguing to think after an RPLND, could we take these tests, especially as our sensitivity for the tests improve, and identify those subset of patients who may have benefited from post-surgical chemotherapy. And then finally, I want to touch base a little bit on advanced stage disease. When patients come in with metastases, sometimes it's obvious they have these large cystic masses and they need an RPLND. And sometimes it's a little bit less clear, as in this image on the bottom right, where they have relatively small residual masses. And we know when we go in there and do these operations, almost half of the time there's not going to be any cancer and there'll be only fibrosis or necrosis. Here's a case of mine, 25 years old, 8 centimeter retroperitoneal mass in the periodic distribution. He had bilateral microlithiasis, a biopsy identified mixed germ cell tumor. He received good risk-directed chemotherapy, and then subsequently post-chemo RPLND with a small focus of residual embryonic carcinoma, relatively uncommon. 5-8% of patients were going to have viable germ cell tumor at RPLND, and sure enough, he did indeed have a positive test. The largest data in this clinical state comes again from Rob Hamilton's group, 82% of 82 patients that received a post-chemo RPLND, an expected distribution of fibrosis, necrosis, teratoma, and viable germ cell tumor. And suffice it to say that microRNAs were quite encouraging, with areas under the curve of about 90% for the prediction of viable germ cell tumor. Not predictive of teratoma, and that's something we kind of know is a limitation, maybe one of the most glaring limitations of microRNA 371 testing. So teratoma is a disease state, disease entity that is, really, again, well within our wheelhouse. We do these big operations. Half of the time there's no cancer. And several groups, including ours, have looked at non-invasive detection of teratoma. When the TCGA came out in 2016, a different microRNA, microRNA 375 3P, was expressed in 6 out of 9 teratomas. And so we investigated 375 3P as a potential biomarker. We had a group of 40 patients. Half of them had fibrosis necrosis only. The other half had teratoma. And when we looked at 375A 3P, the end of the curve was quite poor at 0.506. We looked at the 5P strain as well. These are basically going to be equivalent to a flip of a coin, and we didn't find any utility for 375 for the detection of teratoma. We kind of brought in our approach using all small RNA screens, and here's a volcano plot demonstrating that. We identified 3 microRNAs that were statistically noteworthy for the association of teratoma. And the way it works is the more digits you have with microRNAs, the less likely they are to be meaningful. And sure enough, when we went in and did PCR testing, none of these were predicted. So there's ongoing efforts from our groups and others looking at cell-free DNA, bespoke patient-specific assays to help understand this clinical dilemma of what to do and how to identify post-chemoteratoma. So in this state, I would say that microRNAs are promising for the detection of viable germ cell tumor after chemotherapy. However, there's no reliable circulating test as it stands for the detection of teratoma. So just kind of looking at the whole picture from pre-orchiectomy, I think we're in really good shape and it's exciting. Stage 1 disease, some work to be done with respect to sensitivity, but I firmly believe it's going to be a game changer. Stage 2 disease, the data is robust and it continues to come out. And post-chemo, in that small subset of patients who have viable germ cell tumor, we may be able to really identify those patients. However, identification of teratoma remains an unmet need. So when it comes to early stage testis cancer, I think it's, again, absolutely critical that we maintain these really high oncologic outcomes and prevent long-term toxicity. Surgery for early stage disease is curative in most patients at high volume centers, and it many times mitigates the risk of late toxicities. Cancer care is not a one-size-fits-all. The better we can do with accurate patient-level risk stratification and provide appropriate treatment and avoid under-over treatment, the better we serve these patients. And we do need some novel means to accomplish these goals. And I personally think that microRNAs are poised to fill this gap and impact the way that patients are diagnosed, treated, and surveyed. A little bit of work to be done with standardization, optimization, and validation. This is absolutely a team sport. Over the last few slides are some of my clinical mentors, and here are some of the brilliant folks that I have the good pleasure of working with. So thank you for your attention. Maybe we stop there for a few minutes and see if there's any comments or questions.